Hello, my name is Dr. Maharaj. I'm a hernia surgeon here in Toronto, Ontario, Canada at the Shouldice Hospital and currently practice in hernia surgery here in Toronto. I'm going to explain the Shouldice natural tissue hernia repair for inguinal hernia using an online article here. So here we are, having entered the inguinal canal. We're looking at the spermatic cord here. These are the vessels that's coming from and going to the testicle down below here. The cord itself is covered by this muscle called the cremasteric muscle. Here you can see the indirect hernia sac. It's empty now, but it's right underneath these coverings of the spermatic cord. We will have to separate this sac right here. I'm outlining the sac right here, all the way back here. You can see it's on the superior or on top part of the cord. Indirect hernia such as this would progress down and get larger and larger. It would go all the way down, and you can see it has a straight shot. It is guided all the way down into the testicle in a male. Removing the sac and removing it back into the abdomen is essentially all that's required. There's some very delicate repositioning of muscle that needs to happen to prevent this hernia from coming back out. In the past, others have chosen other ways of fixing this hernia and preventing the hernia from coming back. And one of the ways is to actually put a plastic mesh on the inside or a plastic mesh on the outside here. In either case, we feel that is not necessary. All that's required is using these muscles here, moving these muscles down and this ligament up a little bit, and repositioning this muscle, the cremasteric muscle, is all that's required. So having repair and prevent this hernia from coming back. Now I will show you how to do that. Before I outline the steps of how to repair a inguinal hernia, an indirect or a direct inguinal hernia, I'll just show you this figure here. This is figure number 2, describing an indirect sac or peritoneal protrusion. Here's the protrusion here, that sac that's coming out through this opening here, and usually it's on this side of the cord. You can see we're dissecting this off here. This is just a one step beyond the last figure, showing us separating that sac. The sac doesn't really have to be opened. All that's required is to take the sac and its contents and reduce it back into the abdomen. On very rare occasions, sometimes this sac is so sticky to the cord with all its delicate blood vessels, we prefer to leave part of the sac attached and actually divide the sac, cut it in half, tie it off, and then reduce or push back the sac back through the hole from whence it came back into the abdomen. And that basically protects the cord structures and prevents problems in the future. And at a later video, we'll talk about the various problems that can occur. Doing this operation in what's called an open fashion, where we can see everything, it's much more effective when we can see everything rather than doing it laparoscopically, where this may be more difficult to do using laparoscopic instruments. Now, at this point, we have the peritoneal protrusion or the hernia sac, the indirect sac, reduced back into the abdomen. As you can see, it's no longer here, and the hernia basically has been treated partially. It's gone, it's back where it needs to be, and all the structures that it contained. However, now we need to prevent this from occurring again. Now, this muscle we talked about previously, where this cremasteric muscle surrounds this banana core, as a banana peel. So this peel now has been opened up, and we're about to divide it. And this muscle will actually use as a sling to prevent any hernia from slipping back. And you'll see that in a minute. Here we are now, having divided or cut in half the cremasteric muscle. As a bit of a historical point, one of the surgeons at Shouldice Hospital, this was one of the key modifications that he performed, and that basically showed a drastic reduction in hernia recurrences from about 6% to less than 1% where it is today. This figure basically shows you the back wall, or what we call the floor of the inguinal canal. Here's the cord again, and here's the cremasteric muscle has been divided and tied. Now we open up the floor of this. This is the transversalis fascia. We open up along this line here, and you can see there are blood vessels and nerves going along here. There's also nerves going along here. And we can see these nerves directly. As you can see, where everything's out in the open. Doing this laparoscopically with tacks and various fixation devices makes this very difficult to do safely. As a result, you can develop complications of chronic pain and so on in the future. So here we are opening the transversalis fascia. What you can also imagine here is a big bulge coming right through this very thinned out muscle. You can see there's a little bit of muscle here. There's some muscle, and then there's some fascia as well. And that is all thinned out in what's called a direct inguinal hernia. Direct hernia that came right through the floor of the canal and came right out directly forwards, causing a hernia, a direct hernia. There's a little bony prominence right here. It's called a pubic tubercle, and we begin the repair here. Now we use permanent suture that does not dissolve, and now we will show you the various lines with which we lay down and we reconstruct this groin, not requiring any plastic mesh. Moving on now, we are just completing the first line of this repair. You can visualize as well that this repair, we're not pulling and wrenching these tissues together, we're gently laying them one next to the other. Traditionally, there was a lot of tension placed on these repairs with other techniques, but with this repair, there's almost a shoelacing type effect whereby we place these sutures in a very gentle way next to each other, and it heals very, very well without using extremely tight sutures. One of the things you might hear in the literature and elsewhere is that this places a lot of tension on the repair. As you can see here, and it's very well depicted here, there is no tension. You can have a suture and just hold the needle like this, and there's no tension on this repair, and it heals very, very well without complication. Now, as we alluded to before, we started at the pubic tubercle, and we've ran a suture here in an over and over fashion, and we've caught that cremasteric muscle which we use in our repair and basically snug it around the spermatic cord and basically bring it out this way, obviously staying away from these nerves. We can see them directly, and we prevent complications that way. Here now we've begun the second line of the suture. We've taken the transversalis fascia and actually sutured it up to the rectus muscle down below and the what's called the conjoint tendon, or the conjoined tendon. And we've now come back, having taken that cremasteric muscle around the cord, and then we've come back, and now we're going to run back the other way. So this is a overlapping layer over the first layer of repair. Here now is the third line of the repair, and basically this is using patient's own tissue to reinforce the previous lines of repair, and that's the elegance and the strength of this repair. It comes from the tissues that are in that area that are basically in the wrong place, moved into a new position to allow an adequate repair. We've created a sort of a turtleneck of tissue around the cord, not squeezing it too tightly, and that prevents the hernia from coming back out, the indirect hernia. Now, in that direct hernia where I described previously this weakness coming through here, we now use the ligament and the fascia, the external oblique fascia right here, and instead of it being the ceiling of the canal, we now take part of the ceiling and lay it down onto the floor, and this fascia reinforces the floor of the canal, and you can see this is now the third layer, one upon the next, reinforcing it and keeping it strong, but in a very natural way. So at the completion of this third line, we basically return the suture, again incorporating more of this external oblique fascia down onto this conjoined tendon, and basically reinforce this area and finish up the repair. We then finish by putting this spermatic cord back underneath the external oblique fascia, and essentially what we've done is we've created that collar around the spermatic cord, and basically we've moved the cord so that it's pointing sort of upward, and then it moves back down in its normal way, and in that way we prevent the hernia from coming back out. This area is well reinforced. Put any preserved nerves like this one back into place, and then suture this external oblique fascia closed. We then put Scarpa's layer back together, which is a layer right in the fat here, and then we close the skin with absorbable suture, suture that dissolves, and in no time at all, a patient returns back to work. So there you have it, a multi-layered natural tissue hernia repair, basically approximating the tissues without tension to allow strength to return where there wasn't any strength before due to a natural defect at that site. Hope you've enjoyed it. There'll be more videos coming in the near future.